Boy, yesterday on Twitter, Kathasarian and Verve had some very exciting data about the integration of their compounds into the liver. Again, more aimed at primordial LDL reduction in people with familial hypercholesterolemia. What do you think of that approach, Kosh?
So I think it's very attractive in that it's the, as Sek would say, one and done, and it points to the cumulative exposure hypothesis, i.e. you're taking up the patient non-adherence issue, aren't you? Because you're not giving people 15 different drugs that they need to take, and you basically can achieve sustained reductions. The biggest
over
issue,
a lifetime, over
yeah,
a
for a
lifetime.
lifetime. Yeah, so I think there are two issues there. One is, even with siRNAs with a long duration of action, they're going to disappear. They're going to go. The effect of that is going to go. So we will need longer safety data. And from what I can remember, some of the discussions that I've seen, regulators may want 10 years or longer. That basically means that could well be the future, but it's not going to be the future right here, right now, because we won't have that follow-up safety data. The second thing I would say is, by definition, lifetime cumulative means you've got to think about getting people to do this earlier in the 20 or 30 year. This is not something you want to do in your 80-year-old. You think about most things that we do, often older patients, high absolute benefit, short-term, risk, and they're often people that we're thinking about this treatment in. But we've got to get buy-in from the patients, and I think for the first time ever, we actually have to start having, white papers, discussions with patient groups. How do you feel about the risks, and they're unknown, and the benefits? How attractive is this approach? Because that's going to guide regulators' views of risk benefit and potentially the costing of some of these treatments as well. That's kind of, my thinking about it. It could be amazing. But the same thing, I think one of the things we can maybe take out of the equation, I made the comment that if you start late and you've got more advanced disease and you need a low LDL target, you're going to have to use 2 or 3 drugs. You can bypass that by starting early enough with a smaller reduction that you maintain longer, but conveniently. That means we've got to rethink, reimagine prevention, what our patients want, the doctors buying into this, safety. So
Regulators.
a lot to think about.
The regulatory issue is big, Kosh, because do we need to reinvent how we regulate these drugs? Because, you don't want to wait 10 years to introduce some drug to the market. Well, some people may, but, I think we would have to balance the introduction of a drug with some preliminary safety data with the obligation of the sponsor to provide long-term safety data as part of a provisional approval. I think that would require a lot of discussion, as you're saying, from a lot of stakeholders, patients, regulators, physicians, et cetera. So it's a brave new world, but I think as part of the earlier is better paradigm, it may be where we need to go.
And I think you're absolutely right. So one scenario could be that when regulators talk about 10 years or longer for follow-up, they're doing this under the paradigm of all of the older treatments that they've looked at. So if I don't know and I think that something's got a long duration of effect, fine, I'm going to need longer. Okay, let's say that that is correct. But who are you ultimately doing this for? Regulators' jobs are to protect the patients. Absolutely. Well, let's hear from the patients. There are going to be some people, particularly with inherited conditions or inherited risk, where actually in the way that you've described, providing detailed review and follow-up and feedback from the regulators and oversight, but to then shorten it. Now, that could be persuasive. So an example would be, the perfect example is that we've talked about LPA lowering therapy with injectables, but the perfect example for a one and done for lifetime is LPA. So actually hearing from a patient group that, there's nothing I can do about it, my diet and lifestyle, nothing works, and okay, Now I've got a twice a year or once a month treatment. But let's say I'm done with this. I don't, even have to worry about taking a second pill or anything to lower it further. We don't know what they want. And I'd love to know what they want. And when we listen to that, what a regulator says in relation to what they want, that could be really interesting, because that could reshape that 10-year window into something less.
I agree. Well, thanks for joining us, Kosh. This has been a lively discussion about all these different targets, and thanks to you and the audience for joining us here today.